All right. And welcome back, you guys, to the Self-Selecting Podcast. I am your host, Corey Hagman. Thank you for being here. Thank you for tuning in. As always, wherever you're coming from, whether it's Apple, Spotify, YouTube, those of you who are actively engaged, who rate, review, whatever options you can do that essentially tell that platform this episode or this channel should be pushed out. Thank you. Thank you for doing that. Those of you who comment, even in the case that you're like, hey, I got some constructive feedback for you. Here's what I'd like to see. It is super helpful. So never feel hesitant to let me know if you're like, hey, you went really deep into this topic, but you missed like these key points. I was hoping maybe next time you talk about it. Super helpful. I appreciate it. Then today we are talking about something that, frankly, this week, it's sitting heavy on me because I've had some deeper conversations with other coaches, other professionals in the space. I myself am getting my lab work done, which is really the topic for today. And I'm kind of going into this episode with more of an open agenda. So like certain videos, I'm like, okay, this is going to probably be digested the best if there's like more of a framework and there's an order to how I'm presenting this information. This one, I just want to roll in here and be like, hey, fucking talking about lab work today. And it comes down to the fact that like this makes up so much of what I do on a daily basis. So for those of you familiar, like you already know, like I'm bikini pro. I have been competing for about 10-ish years. I coach, I do one-time consultations, but largely the scope of what I work in and what I help people do is get a better sense of understanding their lab work, using the lab work, like analyzing it to make better decisions. And then obviously with clientele, with people that I'm working with on an ongoing basis, lab work, supplementation, even just like being prophylactic in planning their timeline in the way that we're going to approach, let's say, a fat loss phase or a build. This diagnostic, this tool is really, I would say, like a centerpiece and something that in this space, even individuals that I feel like, I'm like, you for sure know this, like you should know, like you should be able to look at this and even have just a general understanding. I guess what I'm trying to say really is that there is a huge gap. There's a lot of coaches that frankly, they just don't touch lab work, and their knowledge on it is very limited, and that honestly has made it to where in a lot of instances, I find myself kind of co-collaborating, working more as like an interdisciplinary team alongside other coaches and their clients, which I think is like a really cool opportunity and thing that I can do and I can bring to, a client experience or, I don't know, their longevity in the sport. But when it comes to like understanding lab work, I think today the culture is very much almost like awarding brownie points just for a coach or a professional, encouraging getting lab work done, but really past that, not holding like, or not having a set criteria, a set standard of like, well, did they order the right labs? Did they get them timed correctly? Do they have the tools and really the experience to interpret these labs and best advise me? Or are they simply just ordering, asking you to go to your provider, get a CBC, CMP, and looking at, hey, is this within range? Cool, you're good. Nothing's out of range. Like, or, oh, you're slightly low iron. Like maybe we need to adjust the diet. Like to what extent is their analysis actually being done? And specifically with the demographic I work with, many people assume that a large percentage are enhanced. Now, I would say, yes, a large percentage are interested in being enhanced. But when it actually, like, when I unpack this and like look at the amount of clients I work with, the amount of clients that I have assisted in some form or fashion, many are okay staying natural. Many are okay, like, or even just like toying with like non-androgenic PEDs or just TRT. But many are very comfortable not taking that leap and going straight to anabolics, using something in more of like an ancillary way, outside of obviously just like TRT or something like that. But I would say that almost every person I work with, they are interested in having a very clear and objective understanding on what's going on internally, what's going on from a hormonal standpoint. Do things look good or bad? And it's kind of seen in that like very binary sense. Like, if it's not good, that means it's terrible. And if it's not bad, that means it's excellent. And that's very, very far from how I would say, like, I interpret lab work and am able to like help someone see, like, what are the opportunities for really improving, maybe how they're feeling. But I would say across the board, almost every person I work with has some degree of interest in just understanding, like, hey, is there something on labs, or is there a specific lab we could pull that would explain X, Y, and Z, would explain this symptom that I've been having, would explain why I'm not seeing the weight loss that I'd hoped for, or why I'm not seeing like the muscle tissue come on as quickly, or maybe it would even just explain like the current status, that I'm living in, and like, internally the environment that is being created given the phase that I'm in. And I think when we talk about the importance of lab work, really like the key thing that you need to understand is that there is quantitative data and there's qualitative data. There's subjective and objective, metrics, and I would say like definitions, thresholds that, we should pay attention to. And simply going off something that's subjective, that's qualitative, that is self-reported, it doesn't always paint the full picture. I think like generally, myself included, like people are pretty bad at describing a process that might be more advanced than their understanding. And specifically when we're talking about, individuals in the fitness space who are very like hyper aware of changes in energy levels, libido, hunger, performance. I mean, like you have one end of the spectrum where individuals be like, oh, well, like these symptoms are terrible, and they're very sensitive to even like minor changes day to day. Some changes in which like they're not worth really paying attention to. They're completely normal. They're expected. And others on the other end who are not as sensitive, and in turn, like quite, I don't want to say this. They're very numb to states of dysfunction that they've just lived in. So all in all, like, I mean, I think symptomology and like subjective feedback, yes, super important, especially when we're talking about someone who has like a very clear definition of what normal is for them in their baseline. And they've now experienced a specific change from that or deviation from that baseline. But really where I see the value in terms of having the objective data, the lab work, is for one, we can begin to make better decisions around what needs to change. We can begin to explain like, potential causes, or even have a better understanding of like where in the cascade of hormonal biosynthesis is the bottleneck occurring. Because I mean, like surface level, we can be like, okay, like you feel tired. But it's not until we actually look, like really like pull back the shades and be like, okay, is this lack of energy? Is this decreased recovery? Is this testosterone driven? Is it driven because overall globally there is downregulation in all of hormonal production? And where in this cascade does the issue lie? And that's like, I mean, a very like straightforward example when we start looking at cycle timing, specifically like reproductive function for females, really having a clear grasp on like what is normal for the individual. Where are they currently? What is that presenting like from a symptom standpoint? And because of where that's happening in that chain, should we potentially consider some kind of non-pharmacological intervention? So something that's lifestyle related. Do they have the ability to do that? Is there an input that's currently in place that's causing this dysregulation, causing dysfunction that we can, potentially remove, whether that be exogenous hormone, either through hormonal birth control or even through hormonal replacement therapy, or is this lifestyle driven? And in that case, we need to reduce that stimulus. So even within that example, it's like we have to have a very clear understanding of when these labs are being timed and how they relate to one another. And even zooming out further from that, it's like we have to be able to compare trends. And I think in a lot of cases, people will, oversimplify, like, well, I got labs done. Everything was within range, and that's kind of the extent in which they will look under the hood. And let's even talk about like what I said earlier about like someone who's already on HRT. Having labs is really the only way that we can track fluctuations. We can ensure treatments are effective, that we're not like teetering and like slowly coming out of normal to normal high ranges, busting into supernatural, super physiological ranges. They're really important in preventing harm when we're talking about someone who's using a medication, whether in the sports sense of like HRT or anabolics or PEDs, or in the case that someone is using it to correct some kind of system dysfunction or system disorder. And without them, I feel very strongly that like just simply going off symptomology and like that subjective data, you have people that are ultimately going to be left very vulnerable. They can oftentimes be misdiagnosed. Interventions can be misguided. And in some cases, there can even be irreversible damage. So this is something that I found with a lot of people who are open to getting lab work done. It's still the process of finding a provider, finding someone who can help you interpret them, specific not just to like your biological age or your sex or your health status, but also with your concerns, with your symptomology, and with the phase that you're in, specifically if you're an athlete or someone who is kind of dabbling in, I wouldn't say extreme deficits, but fat loss phases that require you to get very lean, or in the case you're a performance athlete and you have goals that are very difficult to meet on account of what is being reported through this lab work. So really understanding that like there's almost this stepwise process. It's not just getting them done and like, okay, cool, I got them done, everything is within range, but it's getting the right labs done. That's important. It's getting them done at the right time, especially in the case of female athletes. And it's also being able to interpret them based on your current health status as well as your goals. That ultimately should guide that intervention and how you approach any kind of modification to medications, drugs, or the program itself. So if you're familiar with my episodes, my free webinars that I've done historically on lab work and like when to time them, what to get, hopefully you find that this is an even more comprehensive, updated version and really expansion on those fundamentals and like just concrete information of like, hey, this is what you should be asking from your provider or telling your coach that you're interested in getting. For those of you who are just like, hey, I have no idea where to start. And frankly, like I know that something's wrong. I don't want to waste a bunch of money. I don't want to waste a bunch of time going to see different doctors only to be disappointed, which that's another side to this is that like you can very much go to a provider. Like I pay a painful amount in insurance. And it's good because it's helped me out because I've had a lot of doctor's visits in the last year. I'm probably going to continue to have more this year. But it's quite disappointing, like how difficult it can be to roll up to a provider and be like, hey, like I pay for insurance. I've paid my copay. I'm having these issues. I'd like to get lab work done. Here's what I'd like to get. And to kind of be dismissed, to kind of be told like, hey, like that's not typical. In this case, it's not something I usually write for. So, we're just going to go with the standard panel or components of a panel that I think are deemed necessary based on what's reported. And this is a big reason that I just go through an a la carte service. It's called Ulta Labs. There's also Life Extension. I know there's a couple other ones, but essentially it's an online service where you can just order the labs that you want to get. You can, in the case of Ulta Labs, you go to a Quest. In the case of Life Extension, you go to LabCorp. You print out the requisition form, you book the appointment, and frankly, I mean, it's that easy. Like you get the lab sent directly back to you. To me, this is even more preferable than going through an HRT clinic. And just disclaimer, it's not to say all HRT clinics, wellness clinics are bad, but we have to acknowledge that they are profit driven. As I am as a business owner, as every coach is, there is going to be a component that, it just has to be accepted that they are going to have a business model that does encourage, yes, you to continue to be supervised, which understandably that can be problematic when patients kind of dip in and dip out. There are regulations that they have to follow that essentially keep them, compliant. And largely within that, there is, I would say, a discrepancy in either what is ordered, what is prescribed, and then the fees associated with having to continuously see their provider and get labs done at different intervals. Not every HRT clinic, every wellness clinic is structured this way, but I can tell you, I personally, I'm very skeptical when you're locked into a contract where it's hey, you have to get labs done every 6 weeks, regardless of what's going on. I'm even more skeptical when in order to get the labs done, that's a separate fee. And then also you have to pay a provider fee to actually meet with them and get the analysis done. It's a tricky situation for private businesses to be in, especially ones who are leaning on the profit-driven side, and frankly can charge whatever they want. So all that to say, if you go that route and you need supervision, and you would like to have someone that you can meet in person, that's definitely an option outside of just going to your primary or even a specialist like an OB or urologist, endocrinologist, through obviously through your insurance. But there are pros and cons to going about it that way. And I work with a lot of clients who I am kind of deemed as a second eye to what their provider is telling them, to either confirm hey, this is what I would have you do, or this lines up and is not going to be dangerous. Realistically, though, there are a lot of instances where people are under the care of licensed professionals, individuals who've been practicing for decades. And let me just be clear, I am not a licensed nurse. I went to nursing school. I have my ADN. I did not take my boards. I do not plan to practice as a nurse or work bedside. The amount of times that I have reviewed someone's labs, I have, been privy to what their provider is recommending, and there are just such serious flaws in either the medication that's being prescribed, in terms of it actually being harmful to the individual, the individual being put on multiple things that some of which actually cancel out the effects of the other drug, the amount of times that individuals have had their sex hormones, females have had their sex hormones tested during their follicular phase, and then having, seen that levels are low, being put on some kind of HRT or TRT in order to support suppressed hormones. It's baffling. It's terrifying from a patient perspective, because I'm very, in the last couple of years, I've been the patient in a lot of instances. It's really concerning to see that kind of neglect and miscare, and even interventions that frankly, I'm if you were to follow that, in my case, if I were to follow that, I'd probably be in a worse off position. So all this to say, I think it's important, if you're going to be under the care of any kind of health professional, whether that be someone who's licensed, unlicensed, public, private, just being very clear before adding any drugs in place, and being very clear on why the diagnoses are being made, what the prognosis is, what the intention is, what symptoms you should be looking out for, because I often find the education, once a diagnosis is made, is very abstract and very lacking. And kind of circling back to the timing of labs, because that's a point of contention I find, and I find to be just very bothersome, given the fact that we know that the menstrual cycle is going to cause fluctuations in serum levels. And I educate my clients on this, is in the case that we're getting labs, we want to time them roughly 7, maybe even 10 days before they start the first day of their bleed. So day 1 of your period, that's the first day of your bleed. You can just count consecutively up from there. So for some people, depending on how long their cycle is, this might be day 21, this might be day 24, this might be day 27, depending on their cycle length, depending on how regular they are. This is paramount if we're testing sex hormones. And it's not to say that all sex hormones are, I would say, like cycle dependent and I guess time dependent. But in the case of estradiol and progesterone, those specifically, and even FSH and LH, like these are ones that have different values depending on when they're pulled. So ladies, boyfriends to women who have potentially hormonal issues. This is what you're going to want to take note of. In the case that you are trying to get a very accurate read of if you're ovulating, it's not good enough to just wake up and decide or go into an office and decide, oh, hey, let's get your labs done today without very accurately knowing where you are in your menstrual cycle. If you get levels checked very early on, during your period, the week after your period, pre-ovulation, all of those levels I mentioned, they can mean something different if they're high or if they're low, and vice versa. If you get them done in the later half of your cycle, those last 2 weeks or right before your period, you can get very different values. So that's an aspect to this. If you're working with a professional, if you're like trying to understand, like, hey, am I going through perimenopause? Is this amenorrhea? Is this something that's going to be longstanding and, potentially pose issues to fertility? It very well might. But without a clear understanding of where you are in your cycle and timing your labs according to that later half of your cycle, and even more specifically, the point in which we're seeing estradiol and progesterone somewhat rise at the same time or very close in proximity, that is going to give us at least more information that is very relevant in terms of understanding where you're at. But that's not to say that we want those same values if, let's say, you're on day 7 or day 10 of your cycle. Those values would have completely different meanings. So it's important just to go in with these things. And that's why I would say anyone who is, really, frankly, anyone who's listening to this, you should be tracking your period. Day 1 is the first day of your period, the first day you bleed, that's when you start tracking. And personally, I like the app Flow. Yes, there's a monthly fee. I forget how much it is, but I really like having that data so I can kind of see over the course of several years, what are the predictions in terms of when should I be starting based on all the data I've logged? What are the symptoms that I generally would expect? What would constitute an irregular cycle? Are there trends that potentially I'm missing? I'm not, tracking subjectively, or I didn't realize are happening around the same time each month. Is there a new onset of symptoms that I should be paying closer attention to that could realistically indicate a different kind of dysfunction or further diagnostics needed? Now, just kind of because we're already covering this specifically, when we're talking about female TRT, something that you have to understand is that individuals are going to vary in terms of sensitivity to drugs like testosterone. And it's not a matter of just getting your serum testosterone levels checked. We also need to look at your propensity to utilize your circulating levels. So this is where I'm a big fan of getting a free test also checked, looking at SHBG, and even past that, especially for individuals who've struggled with acne or just generally oily skin, those who feel like, they do experience some kind of degree of darker, coarser hair growth, whether that's genetically driven or hormonally driven. I would also look at a DHT. I think even prior to looking at all of these subsequent labs, I would also look at DHEA and pregnenolone. And this kind of goes back to what I was saying at the beginning, understanding that if there is some kind of hormonal dysfunction, insufficiency, suppression, we need to understand where in terms of that cascade is this occurring. And if it's occurring further up the chain, let's say even at the point of the very top, like cholesterol, can we look at your diet? Are you on a low-fat diet? Are you eating an amount of dietary fat that, seemingly should be enough, but you've been at this amount for so long and being on the lower side, now you're seeing a suppression in, overall total hormonal production. That's very common and I would say very expected in the case of someone who's going through a contest prep. I've seen it time and time again where individuals will be sub 40 grams of dietary fat a day. The types of fats are not really being monitored. So I mean, like really just like the quality of the fats is not as great, not as cardioprotective, not as neuroprotective. When we start looking at individuals who across the board have low circulating androgens, I think it's really important to understand, is this dietary driven? To what extent can we correct this with dietary support? Also, if we're looking at DHEA and pregnenolone, like are those two that theoretically we could supplement before looking at something like TRT? And I'll tell you, in a lot of cases, I have had individuals who've been very open to TRT, but they've also said like, I don't know if I want to make that jump right now. Maybe down the line, maybe as I get a little bit older, I'm okay with that. But if there are alternatives, if there's more like actual precursor steps that we could take, and very much in the case that might look like DHEA and pregnenolone just overall to support hormonal production. See, the thing is, this is where it gets really tricky. If you look at someone, let's say, who is adequate in terms of estradiol production, their levels are very much within range, yet their testosterone is on the lower side. This is a consideration that we have to make relative to whether or not that individual can supplement with DHEA, as we're going to see DHEA converts down into testosterone as well as estradiol. So realistically, we might need something that is a little bit more specific, and depending on their goals, maybe that is TRT. If there's an option to support testosterone in a different way, maybe we can do that. But this is really where I see the disconnect when we're looking at functional health specialist coaches. There tends to be this lack of care when it comes to understanding the actual cascade and the synthesis of these hormones and where in the chain that disconnect is actually taking place. And also, even if it is, a little bit higher up, do we have the metaphorical runway to use something like, in the case of DHEA, something that's non-specific that will then have downstream effects on estradiol? And in the case that the individual also is low progesterone, I mean, we all obviously should consider whether or not there needs to be a retest done. Maybe the timing of these labs didn't capture that slight rise in progesterone. And if that's the case, okay, we have clearer information. We can make better decisions around this. But what about in the case that the individual is already on the upper end of estradiol in terms of what they can tolerate, and potentially putting that DHEA in place is now going to tip them over the scale and now create symptoms that very much are going to manifest as estrogen dominance. And this is one of the things that I find really frustrating and really disheartening when I see labs and I begin talking with someone about their prior care, and they've been put on things that are intended to lower estrogen, yet their estrogen is already normal to middle range. They're not on the upper end of it. Yet some of those symptoms that are being driven that, I would say predicated the intervention of, let's say DIM or calcium glucarate, or in some cases even Nolvadex or an AI. It's like what they were correcting wasn't actually estrogen dominance. It was normal to normal high estrogen, but still within range. It was just the lack of progesterone that was creating these symptoms for that individual. And in the case that the individual now is suffering from low estrogen as well as low progesterone, and overall feels worse than they did when they were just experiencing that slight elevation, and not even elevation, but just imbalance of estrogen to progesterone. So while we're talking about individuals who maybe are dealing with some kind of hormonal suppression, whether that be perimenopause and ovulation, individuals who've kind of gone the route of TRT, they've made the jump, they've decided, okay, like this makes sense for me. I'm going to have actual TRT in place. I'm not going to go the precursor route of something like DHEA. Let's say they do start that first dose. What does it look like in terms of timing to establish that dosage and to understand really what it's doing for the individual? Well, I'll say what I've seen countless times is individuals are put on a dose. They're asked to come back anywhere from 2 to 4 to 8 weeks to even upwards of 3 months. The individual is told to message in or to call in if they start to experience any kind of adverse effects, any kind of facial hair growth, any kind of excessive acne or other changes, which frankly, I have yet to have a provider explain that like at super physiological doses, if the dose is too high, you can experience things like vocal deepening, like the actual pitch of your voice can drop, clitoral megaly. Those are things that I would say I feel like secondhand what I'm hearing from clients who've met with providers while under my care have been like, yeah, that's never been a part of the conversation, specifically starting TRT. So oftentimes what they're told is to report those unwanted effects or effects that are, kind of out of the ordinary for them. Come back, maybe they'll retest levels, maybe they won't. Oftentimes I've heard people have just gone to see their provider after starting TRT and it's just been a discussion. There's been no labs drawn. It's been more of a consideration of, do you feel better? When you came to me initially, you felt like this. You were experiencing these negative symptoms, these unwanted symptoms of your current hormonal state. Have they improved? And this kind of tracks back to what I was saying before when we're talking about quantitative versus qualitative data. It's important to pay attention to symptomology, and it's important to get a sense of where that individual feels best. But I think in the case of something like testosterone, that can be highly virilizing to women. We have to really rely on that objective data in terms of adjusting the dose and making sure that we're not creeping up into that super physiological level, which it's not like 101 or 110 nanograms per deciliter. It's not like, okay, things are going to change dramatically. To be honest, I've had individuals who've been at 200, 300, 400 nanograms per deciliter for several months. They have noticed very minimal changes. They have, in some cases, they haven't seen any changes. And once they've come to me, it's been like, oh, hey, like you shouldn't sit here indefinitely, even though you might feel good here compared to 100 or even 80 nanograms per deciliter or even 50 nanograms per deciliter. Realistically, if you're going to be on this drug for an extended duration for the rest of your life, in a lot of cases, we just have to consider that the longer that you're in this super physiological territory, the greater likelihood that there is that things will change in a very irreversible sense. Now, this in itself is the big reason that I would rather someone start on a form of TRT that is easy to measure in blood work. So yes, you have forms like the pellet, you have creams, you have gels, you have patches. I think even now there are intranasal options. I'm going to say just my understanding around pharmacokinetics, pharmacodynamics, going with injectable TRT is going to be a route that, yes, it very well might be uncomfortable for some people who are very sensitive to needles and very afraid of needles. But this is going to be the one that delivers the most consistent results and is the easiest to measure in lab work, as well as titrate and adjust the dose if, let's say, that dose is too high for that individual. And let me just be clear, because I had a call this week with a girl who had tried the pellet before, was not a fan of it. The provider came back to her, was like, hey, we can either do the pellet or an injection, but if you do the injection, you have to come into the office. That's going to be a higher fee. It's another cost that they can kind of tack on. But alternatively, if you want to do it yourself and you don't want to do the injections, you can take this cream home and apply it directly, which you have to understand when we're talking about injections for TRT, specifically for female dosing. Female dosing is much less than male dosing. We're talking about 3.5 5 milligrams, 7.5, maybe 10 milligrams for some people every week. That's not every day. And especially if we're talking about pulling up from a bottle, even a bottle that's like 10 milligrams per ml, which is what I would recommend. Lower concentration is going to allow you to do more frequent injections. This is still such little volume. Like it's next to nothing. And realistically, yeah, if it was an intramuscular injection, that would be very traumatic to the skin. I've done intramuscular injections. They're not fun. I don't prefer them, especially for individuals who are low body fat. This can be, potentially problematic and just frankly a turnoff to that method of administration. But in this case, when we're talking about a subcutaneous injection, I mean, this is very much something that It doesn't take a high skill level to do. You can do it relatively safely. It actually does have a lower risk of infection rate compared to intramuscular injections. And realistically, when we're talking about a drug that has such a narrow therapeutic index, we do have to be mindful that we need a form of administration. We need a method that, let's say the levels do come back and they're too high, we can change those pretty easily. So yes, while for individuals who are afraid of needles, they don't necessarily have to go that route. There are alternatives. The concern that really I have when it comes to creams, gels, patches is that I don't find them as easy to titrate the dose. The pharmacokinetics, like how the drug is actually metabolized, is going to vary. And yes, I mean, to some degree based on the individual and the phase that they're in. But even when we look at absorption rates, they're not going to translate as directly as an injection would. And when it comes to ease, I really do think a subcutaneous injection is pretty reasonable for many people. Now, when we're talking about someone who has now started TRT, we have established a dose and we're wanting to see where does this take them to. I mean, I kind of already covered that, like, I don't think we should be blindly going off the subjective data, because I'll tell you, I've had lots of individuals come back with levels in the 200-300 nanogram per deciliter range, not by my doing, but being on a dose that equated to taking them to super physiological territory. Not what I would recommend. And realistically, they've all felt incredible. They felt amazing. Their libido has been through the roof. Their training performance has gone up. A lot of them have seen they've experienced compositional changes because they built muscle. And while I can understand the appeal to this and why this fares really well for providers who just go off the subjective data, we also have to consider that if this individual were to stop checking in, like in my case with me, or if they were to stop checking in with the provider, what is the likelihood that when staying at this dose, that it would potentially pose harm to them, and not even just systemically, like from a hematology standpoint, but realistically, would it cause them to develop androgenic effects and traits? And that is the thing that we kind of have to battle. So simply going off subjective feedback, improvements in overall well-being, like, I'll tell you, it feels good. Yes, it feels good to have anabolics in place. And if I could sit higher without the potential risk, I definitely would consider it. But realistically, there's a threshold for a reason. We know that there is a relative range in which androgenicity is more than likely to occur, and it won't happen overnight. Overall androgenic effects, that is something that we can equate to total exposure over your lifetime. So in the case that someone maybe is at 150 nanograms per deciliter or 200 nanograms per deciliter as a female who's not wanting to transition, sure, maybe the first year they don't experience any changes. Maybe the second year, maybe they start to notice something adjusting. Maybe that's vocal pitch, maybe that's swelling of the clitoris. But realistically, if that person is, if they're really lucky, they don't experience any kind of changes for a long period of time, but eventually that's going to run its course. And that's kind of the framework that I would prefer to work in, and I feel comfortable working in with clients who are on TRT, who are trying to essentially just take their levels back to normal, to maybe even normal high, which that range that I would say we really shouldn't push past is 100 nanograms per deciliter. So when we look at ensuring clients are staying under that, that's where it's incredibly important that we're looking at levels anywhere from 4 to 6 weeks after beginning TRT, after starting the drug. And realistically, in the case that someone is injecting and they're doing injections multiple times a week, what I would like to see is that they inject, let's say they inject on a Monday morning, they go and get their labs Tuesday, so 24 hours after, so that we can establish that peak level. So a lot of providers, what I've been met with is that they will look at the trough. And when I've asked clients, I'm like, okay, what was the thought process with the trough and not the peak? Or was there a specification on when you should get labs done? Sadly, in a lot of cases, there's no specification. It's really just up to the client's earliest convenience. In some cases, providers have told them hey, we want to look at where you are at the low end, because if that's too low, we don't want you to dip back into suppression, or in the case where you're experiencing those symptoms that led you to seek help in the first place. I think this is a huge misstep on like medical care on the provider's part, just because realistically, yes, like we don't want clients to begin to regress and to feel like they did prior to beginning TRT, but at the same time, not at the cost of just blindly hoping that that peak level is still within range. And frankly, in a lot of cases, when I've asked clients, like, what did your provider say you were going for? Like, what was the range that you wanted to hit with this dose? There isn't an established expectation. It's just a matter of, we're going to put in 10 milligrams, 20 milligrams, and we're going to see how you do. And then from there, you're going to tell me if anything feels off or feels weird, or if it feels too intense, and then we can go down. At this point, those of you who are familiar with my content, you've heard me say this 1,000 times. It is a lot easier to titrate up than it is down. When we're talking about levels in a super physiological range, we're talking about levels in the 200, 300, 400, 500, which I've had clients who they've just insisted, I want to sit here. Yet they realize now that their levels could result in them developing male characteristics. So in turn, the only option that we have is to crash their levels, which means removing the drug entirely until we establish something that's a little bit closer to a biological female's natural to normal high range. What I like to do for my clients who are starting TRT under my supervision or alongside a provider's supervision is really encourage that we start at the lowest dose possible. So this, very much for a lot of people, this is going to also be the dose that they probably feel good at and doesn't take them too high. And for most people, that's going to be 3.5 to 5 milligrams a week. Yes, there are cases where some individuals, they go up to 7.5, they go up to 10. Realistically, I don't see a lot of people going much higher past 10 while still staying in that normal to normal high range established at 100 nanograms per deciliter or lower. Now, it's really at the point in which we retest that we can confirm that they are not floating a little bit too high. And at this point, like, yes, there should be checks along the way in the case that it's a coaching client. And I'm like, hey, how are you feeling? Is libido improving? How's your energy? Are you noticing any kind of changes with recovery, with sleep, with training performance? Do we see any changes in your composition? Which admittedly, like, these are all things a provider is probably not going to do. Even a private healthcare professional, even someone out of like an HRT clinic, they're probably not going to be like, hey, let's take a closer look at training performance and really quantify, have there been significant changes? What's your scale weight doing? Do we see a shift in body fat? And that's where I think when we're talking about subjective feedback, yes, it's important to have like clear key like KPIs essentially for things that we're wanting to improve, and then weighing that against once we have that initial dose in place to understand like, hey, is this enough? Now, when it comes to libido, sexual function, this is one that is multifactorial. And there's a lot of individuals who, frankly, even being on TRT, will still experience some degree of abnormality, of dysregulation, of fluctuating levels. So it's not to say just like throwing TRT in place and even putting you at like normal to normal high levels is going to be enough to correct all of the issues. But realistically, this is going to at least give you the peace of mind that low testosterone in itself is not contributing to these issues. And from there, we can kind of determine, is there a lifestyle modification we can make? Is it something you and your partner need to take a closer look at, maybe seek couples therapy? Is it something that pharmacologically, like you might benefit from something that would boost libido, given that everything else is already being attended to and you've checked all of the non-pharmacological boxes that you can? Past that initial check, right around the 4 to 6 week mark. And realistically, testosterone, it doesn't need to be tested if we're talking about relative to like a menstrual cycle. It shouldn't fluctuate, especially when we're seeing an individual who's using exogenous testosterone. I would say realistically, if you want to hit two birds with one stone, like you could get it checked 7 to 10 days before your expected period. That way you can get a good sense as to whether or not you're still having that ovulatory cycle. Now, let's say levels come back they're on still the lower side. So maybe you go up from 10 and now you're at 40 nanograms per deciliter. There's some individuals who will just continue to escalate the dose. And let's say you started at 3.5, you go up to 5 milligrams, you would do the same thing the following month. So you would go back in about 4 to 6 weeks after increasing the dose, get that level checked again. Again, you want to look at the peak, not just the trough. And from there, you can kind of discern whether or not you have more runway to continue increasing. But I would really say at that point, we should kind of weigh it against what is the magnitude in which we've increased levels, and have we really established that you're not going to be too sensitive to that degree of an increase. So in the case of someone who has struggled with oily skin, who has struggled with hormonal acne even into adulthood, this might be something that we want to be a little more conservative on. This would also be something that would be a great idea to get DHEA checked, DHT, free test, SHPG, just to, again, get a really good sense of whether or not it makes sense to titrate up the dose. Now, let's say maybe the first go round, you hit the dose that you want to stay at. Maybe it takes 1 or 2 more times of increasing the dose, or maybe slightly reducing it even. From here, I would keep a very accurate log as to whether or not you're noticing any of those androgenic potentiations. So darker facial hair, signs of oily skin, acne, and this is all like kind of barring that you aren't going through any kind of stressful period in your life where realistically maybe your skincare or your hair care is not as good. Obviously, in the case of like facial hair growth, that wouldn't really have an effect. But let's say in the case that you're going through contest prep and you're also noticing that like you are just carrying a lot of fatigue, like there's a lot of stress on you right now. This would be something that I would say, like, even outside of the dose of HRT or TRT in this case, it wouldn't necessarily be abnormal to see changes in, let's say, hair quality, like just from a nutritional status. Also with like oilier skin, like overall just being more inflamed and being not as resilient in these states. So again, you kind of want to weigh those superficial effects against whether or not you're in a state that potentiates those effects from happening. But I don't think that there's any reason that you couldn't track your vocal changes, make sure that anatomically nothing's changing. And realistically, if you're within the normal to normal high range, so under that threshold, we shouldn't see changes. But it's still something that you have to accept that, like being on TRT, there isn't a guarantee that these things can't happen. So that's where it is super important that you're keeping a very accurate log and you're very attuned to any potential changes that could be occurring, and that you're not just running up the highest dose that you can get away with initially. Past that, I do think that it's important to get levels checked anytime you start a new bottle, anytime you switch sourcing, if you switch to a different carrier oil, if you switch to a different concentration of bottle, if you vary the injection frequency, or even like you miss several weeks and now you're reestablishing, I think it could be helpful. And like in the case of Ulta Labs, you can actually just order these specific values that you want a la carte. And for me, I find that to be very convenient. You don't have the hassle of necessarily having to schedule with an outsourced provider. You're not worried as to whether or not they're going to give you shit for being on TRT, assuming that they didn't prescribe it to you. But then also you can guarantee that you're getting the labs that you want. So in the case that you are able to get those labs and you are able to check them quarterly, that would be my recommendation. It would just be a matter of having the resources or having the tools on hand to understand how to make sense of that information, which I think for a lot of you guys, you can reference my content to at least establish a baseline understanding. This was supposed to be an all-encompassing what labs to get, when to get them done. It turned into more of a streamlined segment around female TRT and the importance of timing labs specific to the female athlete. So I hope this was helpful. You guys, if you have any recommendations below or anything you want to hear more on, definitely let me know in the comments below. As always, thank you guys for watching, and I will see you in the next one.